Through this video, let us see about what is shoulder dislocation. Shoulder is the most commonest joint in our body to get dislocated, and it is because of its anatomical design. The shoulder joint is made up of the scapula, that is the glenoid part of the scapula, and the head of the humerus bone. The glenoid part of the scapula is comparatively small when compared to the head of the humerus. These both structures forms the shoulder joint, and it easily gets displaced because the shoulder joint is more mobile when compared to its stability. The shoulder joint can dislocate of three types: anterior dislocation, posterior dislocation, and inferior dislocation. Among this, the anterior dislocation is the most commonest, that is about 95%, and it mainly results of the fall on the outstretched hand or because of sports injuries. When we fall with the shoulder externally rotated and abducted, the shoulder gets easily dislocated. Posterior dislocation commonly occurs following an epileptic attack, and the inferior dislocation is commonly called as luxatio erecta. When coming to the anterior dislocation, we can see that the patient always abducts their arm and externally rotates, and they often support their arm with the opposite hand. They cannot touch the opposite shoulder with the affected hand, and this is called as Dugastis. You can ask the patient to touch the opposite hand. They will refuse to do, and there will be loss of the deltoid counter following this shoulder dislocation. You can also see the X-ray of the opposite shoulder, and you can compare with the affected side. The anterior dislocation is also of three types, that is the head, how the head dislocates. When the head dislocates in front of the clavicle, it is called as the subclavicular, it can be subcoracoid, and it can be subglenoid. These are the three different types of anterior dislocation, and the anterior dislocation is commonly managed by closed reduction. It is managed by Koch's maneuver, which includes traction, E. external rotation, A. adduction, and I. internal rotation. This is followed in a process and the shoulder is reduced. This is sometimes managed by open reduction too when it dislocates often recurrently. After the immobilization period, we physios can concentrate on range of motion exercises, strengthening exercises, and other protocols so that we can prevent further dislocation of the shoulder, and we can help the people to maintain a normal, functional, and active life. Thank you.